Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre. Afraid I'm not joined by Dr. Renal Epen. For those of you watching on YouTube, I've got an empty seat beside me because Renal is, I don't know, she's pottering around the hospital. She's doing something more important than being on the podcast, which is okay, I suppose. But she might storm in. So if she storms in, great. I feel like I've left my phone behind or my keys behind without Renal here driving the show beside me. So I'll do my best. Put up with me as best you can. But luckily, of course, I've got some fantastic guests to entertain me. First of all, here in studio, a couple of friends of the podcast are coming back. Hello to Dr. Shankar Siva, Associate Professor Shankar Siva. Hi, Shankar.
Hi, how you doing, Declan? Thanks for having me back.
Not at all. Great to have you back. And Dr. Aoife McVeigh, our registrar here at Peter Mac. Aoife, how are you?
Yeah, I'm very good. Very good. So, I can't believe it's even more technologically advanced
our
than the
studio.
last time.
I know.
Yeah, that's what I said the last time. I didn't think it could go any farther, and you just did it.
Here we go. We got big lights. So apparently you need big lights these days. So yeah, it's part of the professionalization of GUcast. We're raising our production values, as they say in the business.
Yeah, amazing.
The lights don't get much bigger than our next guest.
Oh yes. Oh, what a segue. Is that our segue to our fantastic international guest?
Might be.
I suppose we better do that. Why don't we do that? Let's introduce our guest, Dr. Rana McKay, GU Medical Oncologist at University of California, San Diego. Here she is, the big light. Hi, Rana.
Oh, wonderful. Thank you so much for having me. So great to be with you all today.
Did you like that segue from Shankar?
That was awesome. You guys clearly planned that.
Yeah, this is such a heavily rehearsed podcast. That's right, very heavily scripted. But yeah, thanks for joining us. Now, we'll get back to you in a minute, and I will tell everyone who's listening not to tune out because this is not another prostate cancer podcast. You'll all be very pleased to hear. Today, we're talking about Shankar.
Radiotherapy and renal cell carcinoma. Would you believe it?
Oh, I sense we just lost a lot of listeners. Did you have to say it so brutally?
No.
I was just going to say like kidney cancer. I thought that might just edge,
Well, we're talking about kidney cancer too. Yeah.
Yes, so as you might have seen in the title, we're talking about radiotherapy for renal cancer. Really? And that's our theme today. So we've invited Shankar and Rana to come and join us to talk about this fantastic topic. But before we do, Aoife, over to your irregularly regular segment about what caught your eye on social media this week?
Yeah, so a few things actually caught my eye. One of them I had thought about actually earlier in the week because it's something I've seen again and again. And I think they're amazing, and I often point like residents towards them, and I suppose consultants that are listening to this can point their residents towards them, but they're the urology cheat sheets that the EAU produce. They're just normally just one page of PDF on various urology topics, and it's just a really good resource I know I used to print it off for my flexi clinic to remember the surveillance guidelines and, how to identify different risks. And the hashtag for that is hashtag EAU urology cheat sheets. And they normally update them as the guidelines get updated as well. Just a really good resource.
What a nice little tidbit. Yeah, the EAU have this guidelines dissemination committee. It's part of the guidelines committee because the guidelines are so big now. It's such an enormous venture that they have a separate dissemination committee to coordinate how they output all that stuff because the main files, especially on the big cancers, are enormous. So part of their messaging is to have a separate committee to look after dissemination. So I suppose EAU urology cheat sheets might be part of that dissemination thing. Maybe it's probably not purely guidelines, but it's good, isn't it?
Yeah,
good.
They're great.
What else?
On that line, I seen the hashtag EAU 50. I'm not sure if you've seen that going along. So it's the 50th Golden Jubilee. So they're starting to share like sort of the history of the conference and the Congress, and it's pretty nice. So I like all that sort of history of urology stuff. There's another Twitter page, I think it is called History of Urology, and it says on this date this happened, that sort of a thing. So yeah, if you're interested, have a couple of moments on the train or something and want to have a read of the history, it's good.
And they have a good history section, haven't they?
Yeah.
And of course, urology is one of the oldest surgical specialties, and some of the brutal surgical instruments that were used in the pre-anesthetic day for stones and all sorts of obstruction are fascinating to see, to read about. There's some great Twitter feeds doing the history of urology as well. So good.
I bet you there were some nice locations for EAU meetings over the last 50 years.
Yeah, I think it's been heaps. I think one of the first ones they said was in Amsterdam whenever it first started to get up, but don't quote me on that. To check it.
It's always a good meeting. My favorite meeting, as everybody knows.
Yeah. And I'm trying to think what else I've seen. This actually, I'm not sure I'm allowed to talk about benign conditions on this podcast or not, or benign surgeries, but one of the urologists I'd seen had done this amazing animation on HoLEP. So he does it on I think it's a clip art app where you take draw a picture for each slide and then put it together and it makes an animation. And it's a really nice way of describing how you do the HoLEP procedure for patients. And I wonder if it's something that we could do down the line for prostatectomies and things. But I'll send you the link and maybe you can share it on the video so people can see it. Only lasts a few seconds. But that was a Gumas Urologica in Milan in Italy. That's his Twitter name. But again, I'm sure we can tag it.
Fantastic. Yep. We'll put it in the show notes.
Yeah. Sorry, that's heaps. Probably more than I normally get. So I'll stop talking now.
and no Kardashian news this week?
Oh, well, I just, Kim actually got together with Pete in the time that I was on the podcast last. Pete Davidson famously also dated lots of other beautiful women, but now they've split up again. So we'll just have to watch this space for who she moves on to next. Yep. I know everyone will be eager to know.
Yeah, we'll watch the space, I suppose.
Not sure purposeful silence.
I have nothing to add to the Kardashians, sorry.
Yeah.
You were talking about them before, Shankar. You sound like a big fan.
Well, I got the names wrong, so I'm not sure I'm the expert on this.
Yeah, okay. On to more nonsense. Renal cancer and radiation, I suppose. Is that another segue?
I think so. That works.
Aoife, thanks very much.
Thank you. Yep, I have to. We're actually going and removing a kidney tumour downstairs in theatre, so keep it on theme. Keep it on theme. Not with radiation, but we'll see.
All right, good. Great to see you. Thanks very much. So on to the main course. We're going to have a talk about renal cancer and radiation. And look, I suppose Shankar and Rana, as we were chatting about this in the build-up to it, I was just, reminding myself of my not that distant past when the idea of doing radiation for renal cancer was just nuts. Everybody knew radiation doesn't work for renal cancer. Renal cancer is radio resistant. So radiation to the primary was always just something that was immediately dismissed in my early training, certainly. So what I wanted to ask you first of all, Shankar, was how did we get to this point nowadays where this is a really serious proposition for certain renal cancers, first of all, and then second, what we want to talk to both yourself and Rana about is some of the absolutely fantastic trials that are underway that you and your colleagues are involved with. So how did we get here?
Yeah, very interesting question. So I don't think it's that common a misconception to consider that radiation or renal cell carcinoma is radio resistant. In fact, most of the studies that were considering perhaps that we could use radiation therapy in renal cell actually came from in vitro studies in the 1990s at Stanford. And typically speaking, conventional radiotherapy has very little cell kill for kidney cancer, but we're starting to understand using larger doses per fraction of radiation, we are seeing things like a logarithmic type of cell kill with that type of treatment delivery. The issue is that we've never been able to do that safely. So in the past, when we're giving radiation treatment with older techniques, we struggled to get sufficient dose in without causing side effects. And now with the advent of stereotactic radiation, and that be that we call it SBRT or the way we call it SABR here, those treatments are showing real promise in terms of both local control in the definitive setting. There's advantages potentially with synergy with immunotherapy and exploration in the metastatic setting as well. So it's a brave new world.
So it's the biology of the fact this large doses, hypofractionation SABR, that's what's made the difference? And is there a good biological rationale for that? Does it make sense why suddenly this is something that should kill kidney cancer?
Yeah, so I alluded to these in vitro studies from Stanford. So basically what the investigators did, it was Ning and colleagues in 1995, did this study, really simple, had cell survival curves of two of the most common human cell, renal cell carcinoma cell lines. That's the A498 and the CARCI1 cell lines. When we use conventional radiotherapy with doses of 2 gray per fraction or less, it's basically a real big shoulder on the survival curve. So there's a little bit of dose causes very little cell kill. But when we're talking about 6 gray per fraction or higher, which is quite a lot, we typically use 2 gray per fraction or less in standard radiotherapy, then we're talking about logarithmic cell kills. The issue with that is that 6 gray per fraction is quite high, and we can't really do that safely with our standard treatments, where we often give multiple treatments 5 days a week for several weeks at a time. So the advent of these new technologies such as SABRE, SBRT, stereotactic radiosurgery, these are things that are allowing us to actually deliver these very high doses of radiation very accurately. And in the context of primary kidney cancer, since about 2012 when we've started our program, but even earlier than that from the Karolinski Institute, there have been some really promising studies showing good outcomes and good control with these approaches.
Yeah, so there you go, Rana. That's a quick snapshot of how the radiation oncologist started muscling in on this territory. But of course, being very multidisciplinary as you are, as we are, we understand that the best way to start considering some of these good questions like which tumours in the prostate, in the kidney may be managed like this. I couldn't resist it, could I? The kidney, the other one. Yeah. Could be appropriately managed, and very importantly, what other synergy may there be with other approaches? So how did you get interested in radiation for kidney cancer?
So honestly, I think the landscape for kidney cancer has been really changing over the last several years. And I think, historically, we would offer cytoreductive nephrectomy for patients who had advanced disease. And with the data coming out regarding the Carmina trial, the CERTIME trial, really calling into question the role of cytoreductive nephrectomy in the context of advanced disease, I think a lot of us in the field began to rethink what is the role of surgery for people with advanced disease. And, I think even prior to that time, there's always been a consideration for radiation, for multiple indications in kidney cancer. So to name off the few, for people who have a contraindication for surgery, they've got bilateral tumors, they've got, contraindications to undergo surgery, radiation to a primary tumor could be an effective strategy. We've also historically used radiation for palliative purposes, for controlling brain metastases, bone metastases, and those sorts of things. I think in the context of oligometastatic disease and oligoprogressive disease, I think the field has been evolving to employ radiation therapy in the context of people who have 1 or 2 or 3, isolated metastases and actually delay the time to systemic therapy. And then also the reverse for people who are on an effective systemic therapy but may have 1 or 2 sites that are progressing and resistant, though the remaining sites are in a state of response or they're stable, there's an indication there. So I think the field has sort of shifted into thinking about the application of radiation therapy in these multiple disease settings. And I think more recently, sort of the Carmina study being reported out in 2018, again, kind of moving us away from surgery, I think really opened up an opportunity for us to think, well, is there another local therapy strategy that could be deployed? And could there be synergistic activity with immunotherapy, potentially even targeted therapy? There's been a series of studies that have looked at the combination of those 2 strategies with radiation.
Yeah, and I suppose I recall your initial prospective studies here, fast-tracking those where you were taking patients that were surgically inoperable for medical reasons. Traditionally, these patients were just not fit to take to the OR. Is it still fair to say that it's predominantly those patients that you're treating with SABRE? So in other words, patients who are fit for a nephrectomy and whom a nephrectomy or partial nephrectomy might be considered a standard of care. Radiation is not directly challenging that at the moment. In our tumour board, we seem to be still favouring surgery or ablative approaches in combination with SABRE. But I've clearly seen a shift as the data has emerged that SABRE is now rising well up the list, but still not directly competing with surgical excision for fit patients with localized disease.
Yeah, I think that's a fair comment. We're winding back to the primary setting. I think Rana was mentioning a few of the oligometastatic and metastatic indications where there is established roles for these type of stereotactic radiations or even conventional palliative radiotherapy. But in the primary setting for primary RCC, I don't see it as a necessarily competitive technique. There are our initial studies, we were treating for patients who are not suitable candidates for surgery, who might have been high risk for a risk of dialysis, for example, or had medically inoperable or potentially just declined surgery. And the outcomes that we're finding from that initial series of studies back in 2012 are very promising. And as you probably know, we have a multi-centre study called Fast Track 2, which is not very inventive, but that's from the Trans-Tasman Radiation Oncology Group. We're hoping to read out some results within the next 6 months or so. That recruited 3 years ago, and so just getting the median follow-up up now. So in that setting, I think it's very complementary to surgery. The real question is, where does it fit with thermal ablation? Because SABRE has the capacity to treat larger tumours, typically over 4 centimetres in size, whereas thermal ablation, including cryotherapy or radiofrequency ablation, becomes more challenging in those tumours that are close to the renal pelvis, or tumours that have are larger, because the complication rates get higher and multiple treatments are often required. So, in our multidisciplinary board, when we see these patients, we often discuss all of the options. Since 2022, we have SABR for primary RCC recommended in the NCCN guidelines. There's new ASTRO RCC guidelines, as well ASCO RCC guidelines that have had some recommendations of metastatic RCC, and hopefully the EAU guidelines will catch up in the future too. But there's certainly an indication, and it's guideline recommended now.
I reread the EAU guidelines this morning, and they're still understandably cautious, saying awaiting further prospective data. So it doesn't actually get a recommendation, but that's probably realistic as well, isn't it? Although we tend to be using it quite a lot more enthusiastically than a few years ago, I think. Shankar, now Renu has joined us. Those of you watching on YouTube just saw she popped in. Hello, welcome.
I heard there was this interesting discussion going on, so I
just before you go down to theatre and take out some kidney tumour.
Exactly. Should we give radiotherapy instead?
Yeah, no.
Is that what you're talking about?
Yeah, that's right. No, we're being very reasonable here, and Reina's on the line from San Diego.
Hello, nice to see you, the famous Rana.
So,
thank you for having me.
So one of the questions that, we always have, surgeons certainly have, everyone has, I suppose, in looking at a renal tumor, it's often in a single kidney. It's had a nephrectomy already, maybe we had one this morning, and the tumour board just remind us, what is the local toxicity for SABR nowadays how do you select a big chunky kidney, small chunky kidney having radiation? So in summary, because that used to be one of the things that put everybody off as well, not just that traditional radiation didn't work, but also there was renal toxicity.
So from a renal function perspective, we've actually published multi-centre data from the International Radiosurgery Oncology Consortium, looking at multiple cases, about 200 or so from across the globe. Overall, the renal function rates of loss are relatively low. So on average, if you put a rough rule of thumb, it's about 7.5 mils per minute of EGFR that we see in the longer term. And it climbs up to about 10 around about 2 or 3 years down the track. In the solitary kidney, it's pretty similar. So the reason I can see that is because in the patients who've got bilateral kidneys, they often have other medical comorbidities that can cause renal function decline on their own, and therefore they're just a bit more crumbly. The patients that we see with a solitary kidney after a prior nephrectomy are often younger and fitter, and they tend to preserve their renal function pretty well, even though we're treating a solitary kidney. So on average, it's about that 7 to 10 mils EGFR rate. The toxicities from another perspective, we do see the occasional bowel stricture. That's a less than 5% risk. And then flank pain, which I counsel my patients about 5 to 10% risk as well. But overall, it's really well tolerated and, good outcomes. Yeah,
look, I agree with you. I think the data stacks that up. Is that the consortium? Is that the IROC consortium? Goodness me. So, Reina, is that your take? This seems to be well tolerated from a toxicity point of view. It's not preventing you from being able to offer these patients systemic treatments?
No, it's pretty well tolerated. I think it's non-invasive, so I think that's another difference with ablative therapies, which, you have to percutaneously access the tumor. So I think there can be risk associated with that. And, certainly Shankar could speak a little bit more to this than I can, but using DVH parameters, really there's kind of very strict criteria to minimize toxicity to the bowel. I think the unique thing too about where the kidney sits in the abdomen, it's in the retroperitoneum. It tends to be far away from a lot of critical structures, I think. That those things kind of basically make it really a palatable option for, especially in the localized setting when somebody is really not a candidate for surgery. It does not really want to go down that route. That could be an option. And certainly thinking about application in the context of, people with systemic disease. There's been a series of now studies with, TKI-based treatment for treating the primary and other metastatic sites, and now a series also with IO-based therapy, really demonstrating pretty minimal grade 3 and higher toxicity with SBRT.
Yeah, it's great, isn't it? And I think it's so great to have this technique, as in the armamentarium to treat kidney cancer. And Shankar, I've certainly referred quite a few patients to you for SABR of renal lesions. And the reason I think it's important for this sort of data to get out there is that a lot of people think that when patients are referred for something like SABR, all of a sudden now you're palliating the situation and they're not a candidate anymore for curative treatment. And that's just not the case, is it?
No, and often we've saved the option of salvage nephrectomy down the track. doesn't happen that often.
Yeah.
So, but it is always an option down the track.
And Shankar and Rana, in your opinion, who are the patients who are not good candidates for this? What are the sort of lesions, and who are the sort of patients that you wouldn't think are ideal for this?
Perhaps, Rana, do you want to talk maybe in the cytoreductive setting? Which patients would you think would not be good?
Sure. I think in the cytoreductive setting, for people who have widespread metastatic disease, if their systemic disease is out of check, it doesn't really make sense. I think in the context of people with systemic disease that are on immunotherapy or doublet therapy, if they're doing well and have had a great outcome, and you're thinking of sort of strategizing their therapy, can they get sort of cytoreduction with radiation? I think those patients are good candidates. But I think in the context of people who are not having their systemic disease in control, it's really hard to really think about offering them radiation to the primary. I think also for people that are really struggling with a lot of side effects just from their systemic therapy, and there isn't an indication for them to receive therapy for their renal tumor, I think those people are not great candidates. Maybe they're having colitis from their combo IO TKI. They've got bowel next to the kidney, and then you're kind of, why am I offering them radiation to their primary? So I think in those settings, I tend to defer. But those are the considerations for systemic disease patients.
Yeah, so I'll address the primary setting. So I think patients who are clearly operable, who are fit and young and can have a primary lesion without any metastatic disease, I think those patients should be considered for a partial nephrectomy whenever possible. When there are patients who have needed, say, a total nephrectomy to address their disease, radical nephrectomy, and we have other comorbidities or potential issues with pre-existing chronic kidney disease, then these patients you may consider for SABR. And for the smaller tumours, I think that's one I'm not super enthused about. I think outcomes with maybe patients who are a little bit older who have smaller lesions for either active surveillance, thermal ablation, SABR, or partial nephrectomy, they're all great approaches. So, I'm not so fussed about that group. I'm more interested in the patients who really need those treatments to be able to survive longer.
The kidney moves a bit on respiration, doesn't it? So, and I remember years ago you showing me these nice cine MRI movies of the kidneys moving, and you had some complicated planning, but it was dramatic how much the kidney was moving on cine MRI. So how does that work in SABR?
Yeah, we normally get a urologist there to push on the abdomen while we're in there just to make sure it doesn't move. Yeah, exactly. No, that is a complicating factor. There are lots of technical issues. SABR for the kidney is not easy. It's one of the more challenging treatments that we do have for when we talk about SABR in general. But one of the things that we do look at is motion management. So there's several different strategies for that. One we use here often is actually vacuum compression. So the patients get a bit of a cling wrap on top to keep them a bit more immobile. And the other option we can do is gating, so switching the beam on and off when the tumour is in the right spot and the kidney's frozen in motion.
So how do you see the kidney moving?
We have cone beams. We have CT imaging on the machine, which allows us to take pictures of the kidney while the patient's breathing. We have infrared markers on the patient's surface, and that tracks their breathing, which is also a surrogate for the kidney. There are newer technologies as well. There are technologies that require marker placement, so things like CyberKnife can be used to actually track the tumour as well. The issue with that is that these tumours are often hemorrhagic, so sticking things in them is not ideal. So, I tend not to prefer those approaches. And finally, there's the MR-Linac, which is showing a lot of promise because also that is able to image at the same time as treating.
Rana, do you always get a renal biopsy before referring for SABR, or is that how important do you think it is?
So, very good question. I think if we don't have a tissue diagnosis, I do try to get a tissue diagnosis. I think knowing the type of tumor that they have, a lot, not to say a lot of times, very rarely, sometimes these come back as a urothelial cancer if they're kind of misplaced. So I do always like to try to get a biopsy, understand the histology, understand the grade, understand, is it a clear cell RCC? Is it an unclassified, poorly differentiated carcinoma? So I do think that is, if there is no other tissue diagnosis, I do refer for one.
Yeah, because, for partial nephrectomy, often, we obviously have histology, and, if we're doing percutaneous treatment, such as cryo or radiofrequency ablation, they'll often do a biopsy at the same time. So this would be one situation where you'd biopsy first and then refer.
So you also, the pair of you, published a very nice review in European Urology last month, overviewing this area, you and William Hall, and I can't remember what other, a really, really nice piece. So I thought that's, for those out there, we'll put a link in the show notes, but that is, if you want to read a little bit about how we got to where Sabre is today in kidney cancer and where we're going, European Urology, beautiful review with Shankar and Rana. But do you want to summarise, you reported, for example, the local control rates in that for the primary and also for brain mets and stuff like that. Shankar, do you want to just remind us what you reported, if you can recall?
Yes, so I think the data is pretty consistent across all the different sites. From a local control rate, when we talk about local control rate 1 and 2 years, it's above 90%, typically about the 95% rate. And the grade 3 toxicity rates from these treatments are also pretty low. It's around the 5% rate. And this is on across all the different body sites that we treat as well. I think one of the things that we need to look at in the long term is try to get long-term data from any kind of ablative techniques. We don't really have very good long-term data either for RFA, cryotherapy, or even Sabre in a prospective setting. So it's really important for us to be able to capture this long-term data from the primary. There's better data in the metastatic setting, but again, the patients may not survive as long for us to be able to capture that data.
And you mentioned that it's tricky. So when we think of things that are tricky, like sent into specialist centres, Sabre technology is becoming more and more widely available. So should these only be done in specialist centres, or if anyone's got Sabre and some experience with Sabre for other things, lung and prostate stuff?
It's a very good question. So I get emails a lot from internationally about patients, other clinicians sending through potential cases that they may be considering for Sabre for the kidney. It is a newish indication in a lot of centres, and so I do encourage everyone to contact someone with experience to get some advice. We were able to roll out quite a good quality assurance program with our TROG, Trans-Tasman Radiation Oncology Group study, and that allowed to bring up a lot of clinicians up to speed in this technique around Australia. So it is potentially tricky, and I think one thing you can do is really easily get nervous and underdose the tumour because of its location. So for primary kidney cancer, I would really encourage people to reach out, get some protocols, get some understanding, get some experience, and join NRG trials. There's a very nice NRG trial coming up that will be a really good approach to get your quality assurance and get your contouring up to speed and treatments up to speed.
And we definitely want to talk about that. So what's the dose? What roughly are you aiming for? Is this all single fraction or?
We use two approaches, single fraction for tumours of less than 4 centimetres in size and 42 grain 3 fractions for larger tumours. And that's pretty standard.
Does it work for cystic tumours?
It does. I think the problem is the cystic tumours, it treats the solid component of the cystic tumours. So the cyst will always be there, it'll always look like that, but the solid component will be the bit that we treat.
And Rana, you work with some fantastic radiation oncologists. You got a big team there, Tyler Siebert and your colleague and co. They're very up to speed on this program and very enthusiastic, I'm sure.
Yeah, no, it's been great. And I really want to piggyback on what Shankar had to say about the NRG trial. I think what's so great about trials like this is this trial is actually doing real-time treatment plan reviews for all patients that are undergoing radiation. And so it really is a good opportunity to actually get up to speed with the planning, have sort of our team of radiation oncologists, Shankar being one of them, will kind of do those reviews in real time and turn it around to the treating clinician, and just as a quality control. And I think, trials like that are being open across academic and community sites really to actually help, bring this technology to not have it be something that's just a niche thing, but with training, with appropriate quality control, it can be implemented a little bit more broadly.
So that's the Samurai trial. Yeah.
Yes,
do you want to tell? So we'll put it.
I feel like I need to. I need to make like a hand motion.
Yeah, exactly. So go back a bit. I could see there was a lot of excitement when that trial got initiated, NRG trial. Can you just tell us a bit about that patient population, Rana, and what's the goal? Because this is a classic multidisciplinary trial combining different modalities, isn't it?
Yeah, and it's actually the first trial of radiation therapy to the kidney in the metastatic setting through any of the cooperative groups. So it's really kind of, I think, a landmark trial. The goal of the trial is really trying to cytoreduce in the context of people with intermediate and poor risk renal cell carcinoma who are not candidates for upfront cytoreductive nephrectomy, who are receiving doublet therapy that is at the choice of the clinician. So the trial will allow patients to receive Nivo/Ipi or any one of the other IO-VEGF combinations. Patients will be randomized 2-to-1 to receive radiation to the primary, given at 42 gray over 3 fractions versus just systemic therapy. And the systemic therapy can be initiated prior to the SABRE treatment, and then will be held during the course of the SABRE treatment and then resumed thereafter. So I think it's a great trial. The primary endpoint is radiographic progression-free survival. We will be tracking patients who undergo subsequent nephrectomy for any reason as part of the protocol, and actually embedding that into the primary endpoint as an event, at the indications of NCI and GU steering. So we're really excited about this protocol, looking at lots of quality of life endpoints, looking at, baseline archival specimens, and looking at correlates of response to radiation as well.
Wow.
Yeah, that's superb, isn't it? So that's
Exciting
like going
stuff.
back to re-challenge the role of local control as the cytoreductive studies. Carmina changed everything when that came out. It really challenged us to think, well, maybe we weren't helping a lot of those patients when we were doing nephrectomies, as it turns out. It definitely was a big practice change when that happened, but it's very important to go back in, I think, and see local control on that primary. And of course, we know maybe select patients, of course, will still have a cytoreductive nephrectomy, but I think this is a great trial. I must say, I think it's one of the best trials I've seen open this year. Yeah.
And the other thing is, it may not just be the cytoreduction or the local control component. I mean, we are seeing some synergy with immunotherapy with stereotactic radiation. We had our own study here at Peter Mac called Rapport that was published in European Urology earlier this year in April. Made the front cover, which is was very excited about. Told everybody, including the dog. And so that kind of study, we could show very good synergy with local control and a low toxicity with the additive toxicity of the radiation and the immunotherapy. That's consistent with other studies, like the toxicity piece is pretty well spoken for. Like, there's not a lot of additive toxicity with immunotherapy and radiation, or even TKI and radiation. What we are really interested in is that systemic synergy, and I think that piece needs to be spoken for in larger randomized trials.
Yeah, wow.
What do you call that imaginary thing again, where radiation reveals?
Abscopal effect.
Abscopal effect.
That's right.
There we say it. We said it.
It's a radiation unicorn, right?
A lot of hand waving,
Imaginary
right?
effect.
It is funny. It's an imaginary thing, though, isn't it?
But I do think it's worthy of investigation in a prospective fashion.
Yeah,
Definitely.
Hopefully, there's a few radonks out there, and somebody will be outraged enough to, email us and tweet us and say, "Let me send you all the data on the abscopal effect." It's not imaginary, but I think it's imaginary. I don't think it is. So look, that's fantastic. That's a great trial. I'm very enthusiastic, and that is an NRG trial. So just the US sites, Rana?
No, I think the hope is that we're actually going to open it in Australia as well, and potentially, I think possibly also Canada as well. So there's another trial called CytoShrink that right now is enrolling in Canada. And that's being run. I think the PI is Ali Khan Lalani. What's unique about that trial is it's only being done with the combination of nivolumab plus ipilimumab. So our trial is a little bit larger and will allow for the other IO-VEGF combinations. But actually, we've been collaborating very closely with the CytoShrink team. And even hopefully at the end of the day, we can analyze the data for both of these trials together and kind of learn from each other.
Yeah.
Is CytoShrink open in Australia?
We've got that here.
It is, yeah.
That's right.
We're
the only centre out of Canada that's open at the moment. So
Yeah.
Yeah,
Fantastic.
And great to hear you're all going to work together on that, and we'll get that data.
It's like the kidney dream team.
Awesome. It is great, though.
Love it.
We should do more kidney stuff.
Yeah, definitely.
I'm sure everyone else agrees. Just why do we do so much prostate cancer on this bloody podcast?
might have to do it with you, Declan, maybe.
Maybe do it with me, yeah. Anyway, it is great to talk about other GU cancers, to see this great stuff ongoing, and congrats, Rana and Shankar, on that.
Absolutely.
So great messages, yeah. There's a reason why it's no longer radiation for renal cancer, really, as we were sort of mocking ourselves, that it really is emerging. And even though guidelines are not fully embedding it as a strong recommendation, clearly we've seen that there are select patients, this definitely works and is well tolerated. and it's very, very exciting to see big trials like this getting going to really
definitely
cement the role. And I'm sure that's that we're well on the way to all that stuff emerging into high quality evidence to change guidelines. So well done to everyone involved in that field out there.
Watch this space.
Great. Well, and Rana, thank you for joining us. It's been great to have you on the podcast. When you've never been to Australia, you told us beforehand, so we'd love to have you down here.
Not. Yeah. No, my daughter's name is Sydney, so we got to make it out.
Yes.
His name is Sydney. There you go. You were thinking about that. You said, we're going to go down.
Just toss up between Sydney and Melbourne, right?
Maybe Adelaide.
Melbourne, McKay. Yeah, look,
we'll send you a care package.
We'll send you a fantastic. Awesome. Great. Look, thanks so much. Well done to everyone who's been involved in this. Shankar, thanks as ever for coming in and talking to us about this topic. It's been very enjoyable, hasn't it?
Really has.
Yeah.
Great topic.
Great. If you've got other stuff you'd like us to talk about, of course, we love to hear suggestions of stuff to talk about on GUcast. Always want to talk about something that's not prostate cancer. So please just send us your suggestions. Rana, have a good day and thanks very much for joining us.
Thank you. Bye-bye.
Bye.